Hello, everyone. This is Anna Maria Tirano, Vice President of Marketing at Cinzy. Thank you for your patience in joining our webinar today. Welcome to today's webinar featuring the latest news regarding the Chronic Act and expanded coverage for virtual care, including new telehealth provisions. This presentation is being recorded, and we will send a link to the recorded webinar to all registrants and attendees after the webinar concludes. All attendees are muted during today's presentation. If you have any questions at any point during the presentation, please type your question into the chat window on your control panel. Depending on the question, our presenters will answer it at the conclusion of the webinar or follow up directly with you after the presentation. Today, we welcome topic experts Craig Smith, partner at Hogan Lovells, and Brooke Bumpers, counsel at Hogan Lovells, who will share their insights on this topic. Having served as general counsel at one of the nation's largest state Medicaid programs and healthcare regulatory agencies, Craig is highly qualified to advise healthcare industry clients across the nation on complex regulatory issues in transactions and disputes. Brooke has spent her entire legal career working with healthcare and life sciences organizations, helping them understand federal and state regulatory and legislative issues to resolve their problems. She has advised healthcare provider and payer organizations on regulatory issues related to telehealth services. Thank you for joining us today, and I will now turn it over to Craig and Brooke.
Thank you, Christina, and welcome everybody. Thank you for dialing in today. We have a pretty packed presentation for you, and we want to leave some time near the end for questions if anybody has some. So let us jump right in. Before we start with the first slide, though, I just wanted to introduce Brooke and I a little bit more to you. We both spend a fair amount of our time these days as telemedicine and telehealth and digital health has been expanding. We spend significant amount of our time advising clients in this area, and the types of, just to give you an idea of types of questions we get questions from health systems, hospitals, and other provider-type organizations on how they can properly utilize remote physicians, remote non-physician practitioners, and still be reimbursed by payers, because that's a thorny area that everyone's trying to navigate. We get questions from companies that have designed their entire business model around providing remote health care, whether it be a company that focuses on providing specialist physicians from a distance to a healthcare company located in one geographic region. That's another area we advise companies on. We also get questions from investment companies, private equity, venture capital firms looking to make investments in this industry sector, but they don't necessarily know the business risks and compliance risks. So we help them understand the compliance landscape and help them understand whether there's reimbursement available for these services in the type of investment they want to make. And then lastly, we spend time advising technology companies that they don't have the physicians, they may not have the ARNPs or other professionals who provide the care, but instead they make the equipment or provide the capacity for these types of telemedicine communications to occur. So the questions come up from many different directions, and hopefully we can dive in today and explain some of those new developments for you. If we move to slide 1, which may actually be numbered slide 2, this is just an overview of what we intend to talk about today. If we can go back, yep, there we go. We're going to talk just briefly about what exactly is telemedicine and how did it start. There's so many different terms being thrown around in the marketplace today: telemedicine, telehealth, digital health, mobile health. Let's spend a few minutes this morning and this afternoon getting grounded on those terms. What are some of the industry advances in telehealth that are really driving this sector? What are the new and limiting state licensure laws that play an important role here? And then we're certainly going to talk about the new Medicare requirements as well as the previous Medicare requirements so that you can understand why this is evolving, as well as some of the Medicaid program reimbursement standards that apply. So if we move to the next slide, how did this start? Well, like many innovations in our society, believe it or not, telemedicine really got its foundation through the space program. NASA was trying to figure out, what do we do if one of the astronauts becomes ill in space? How do we deliver care to those astronauts? And so they developed systems that could provide essentially a foundational version of telemedicine, communicating with healthcare professionals on Earth to astronauts in space. And so it was the learning from those episodes that helped launch the telemedicine industry. And if you go to the next slide, you can see that even back in 1974, NASA recognized that this type of approach, using the space technology to deliver care, has spin-off potential. And they even anticipated back then that this could be extremely beneficial to improving the quality of healthcare delivery here on Earth. So pretty fascinating starting point, going back over 30, 40 years. And from that, we've seen many innovations and developments into what telemedicine or telehealth is today. And so moving to slide 5, I'll turn it over to Brooke.
Good morning, everyone. So I guess the first question is, what is telemedicine? How is it defined? And unfortunately, there's really not one universal definition of telemedicine, and that can complicate things legally. A particular law may or may not apply depending on how the term telemedicine or telehealth is defined and the specifics of the services being provided that are subject to the law. So it's important to pay attention to the rules of telemedicine and how those terms are defined. But the World Health Organization has what I think is a good broad definition, and it can encompass not only the diagnosis and treatment that we usually think of when we think of telemedicine, but also can be for the purposes of research or continuing education or for public health purposes. Next slide, please. But today our focus really is going to be on what most people think of when they hear the term telemedicine. And that really involves the use of technology to share clinical information between healthcare professionals across some distance in order to diagnose or prevent or treat illness or injuries. So that's what we'll focus on today. Next slide, please. Although, as we'll discuss in a minute, this universe is getting broader and includes some services that are outside of the kind of traditional realm of what most people think of as telemedicine. Historically, there was really a distinction between what's called asynchronous store and forward technologies versus synchronous or interactive technologies. And Medicare and many payers have traditionally only covered telemedicine services that involve synchronous or interactive technologies in which a healthcare provider and a patient can have some sort of real-time interaction or sharing of images in a way that is sort of similar to a face-to-face physician visit. And so this distinction is still important in many contexts, although it may be less of a bright line as more and more data becomes available from things like remote patient monitoring, and that gets incorporated into the telehealth or telemedicine interaction. Next slide, please. So, the other thing is, what is telehealth? What is telemedicine? What are all these terms? What's the difference? As with telemedicine, there really is not a kind of universal agreement on what telehealth means, but it's generally used more often now than telemedicine, and it's kind of a broader term that can encompass the provision of a wider array of health services using technology. And it's less likely to be limited to the traditional sort of physician visit model that we, more typically think of. Next slide, please. As Craig mentioned, you also now hear terms like digital health or mobile health, and increasingly with the kind of explosion in the use of technology to monitor and analyze and deliver clinical care, or share information or provide services, you hear the terms digital health and mobile health. And telemedicine has really almost become a subset of these broader terms, and other types of technology are incorporated into traditional telemedicine visits. Some of these services, are for health or wellness purposes, but not necessarily clinical in the sense of providing medical advice or services. Something like the Fitbit is often used as an example of these wellness type services. But honestly, sometimes it's hard to tell where the line is, and there are definitely gray areas where it's not always entirely clear when a wellness app or service really morphs into something that's providing kind of actionable clinical information that may then be considered to fall under the definition of the practice of medicine. And I've certainly had discussions with my colleagues in our FDA group about whether and when certain devices or applications would be considered medical devices and subject to FDA regulation. So that's definitely an evolving area. It's not terribly well defined yet in some cases. And then increasingly, there are devices that can gather and transmit a wide range of health-related data that can be shared both with the patient as well as with healthcare providers. That includes things like glucose monitors, remote cardiac device monitors, and these may also be, part of what we think of as telehealth. And now I'm going to hand back over to Craig for a bit to talk a bit about state law.
Thanks, Brooke. When companies come to us for advice in the telemedicine, telehealth space, we try to break down the types of laws and regulations that can apply to their ventures into really two main categories. One is the types of laws that apply to restrict or limit what they are doing, and that's usually in the delivery of care. And those tend to be mostly state laws. State law, if you think about, you put aside telemedicine for the moment, just the delivery of health care, states regulate the professionals in the licensure acts on how they can operate their professions. States regulate, from a licensure standpoint, the healthcare facilities that where care is delivered. And so it's a state law mechanism that governs the actual delivery of the care, by and large. Then separately, you have laws regarding how do you get paid for the delivery of that care. And Brooke's going to talk about the Medicare rules that apply from a federal standpoint on payment for the care. But first, let's talk about the state laws that regulate this delivery of care. And frankly, most states were well behind the curve in addressing telemedicine and telehealth. The state legislatures didn't really anticipate some of the quick online delivery of care, if you will, especially there were a number of online pharmacies that popped up and made it possible for people to order and receive prescription drugs without having any type of in-person medical visit. And therefore, states tried to quickly come up the curve after it became clear that this was happening. And I'm going to use Florida as an example because this is where I sit, but many states have similar laws, but the important thing to keep in mind is you have to look at the individual state where the delivery of care is happening in order to make sure you're in compliance. And by and large, those rules depend on where the patient is as opposed to where the healthcare professional is sitting. And so, for example, the Florida Board of Medicine has regulated the ability of physicians to practice telemedicine for at least 10 years. They've had a specific rule on this. And the foundation of the rule is that the standard of care for doctors to deliver health care and medical services to patients is the same regardless of whether you're in person or you're not in person, if you're appearing virtually or doing some type of online communication. And if you go to the next slide, you can see that their rule, it regulates the provision of the patient care or treatment regardless of the mechanism used. If it's exchanged from one site to another site in an electronic format, a physician's care and physician's treatment advice, then that's going to be governed by the board's rule. It would not include things like telephone, email. Those are not considered telemedicine. But having said that, the standard of care still applies. So, for example, if a doctor if a patient wanted to receive a medication prescription from a physician in Florida, the type of medication and the request will dictate the standard of care. If you go to the next slide, you can see that the standard of care doesn't really change, and you can have the possibility of a physician-patient relationship being established through the use of telemedicine. So, for example, it would be possible for a patient sitting in one city in Florida to have an established doctor-patient visit electronically with another physician in Florida. However, if the reason this is an important part of the rule, and it's a type of rule that many states have adopted, is that if the patient is sitting in Florida and let's say they use FaceTime or Skype or some other virtual video conferencing tool to have a doctor-patient visit with a physician sitting in another state, and that physician sitting in the other state is not licensed in Florida, there is a high chance that the physician is improperly practicing medicine in Florida without a Florida license. Now, there are some exceptions to that, but generally speaking, that's how most states approach this type of regulation. If the patient is sitting in Florida and you're having a primary physician interaction rather than a specialist interaction, there is the risk that the doctor could be subject to licensure sanctions if the doctor is not licensed in the state where the patient is sitting. There's also, on the next slide, the Board of Medicine has created two rules in Florida, again, similar to other states, that restrict the prescribing of medication. One is that controlled substances may not be prescribed through the use of telemedicine. So that's a pretty strict rule, which has been important in Florida for opioids and other types of controlled substances. But then also, the board has decided that prescribing medications based solely on an electronic medical questionnaire constitutes the failure to practice medicine within the requisite standard of care. So they've decided to put that kind of marker in the ground and say we're not going to allow physicians who have never seen a patient prescribe medications for patients. We want them to see the patient. But if you note in that quote, the rule does not say they have to see them in person, face to face. So it leaves open the possibility that for certain medications, if a physician determined that it's within appropriate medical standard of care to have a Skype consultation, for example, and have a face-to-face video conference, perhaps the physician decides that is enough for the prescription of certain medications. Or maybe what we're seeing a lot of developments here recently is, whether it be in a shopping mall or other retail site, there are the development of kiosks where a patient can go remotely connect via video with a physician, At that kiosk, there might be a blood pressure gauge. There might be the possibility for the patient to take the temperature in the plain sight via video of the physician. All of these technologies are being developed to accommodate these types of state laws that say physicians cannot prescribe medicine without having ever seen the patient, but this type of further development of technology allows the physician to satisfy the standard of care. If you move to the next slide, they need to, the physicians or ARNPs, usually under most state laws, they need to document that they've had a patient evaluation, including history and physical, before they start prescribing medications or prescribing other therapies. It's important to document that they've discussed with the patient treatment options, including real-time, in-person treatment options versus telemedicine options. And then most state laws will require the physicians or other healthcare professionals to maintain the contemporaneous medical records for purposes of satisfying the licensure rule. Next slide. What many of these state rules do not prohibit, however, is consultations between physicians where the only thing happening electronically is the transmission and review of a digital image, such as an X-ray or an MRI. The electronic transmission of specimen test results, for example. Two physicians can consult about that in the care of a patient, and that's usually not governed by the telemedicine rules in any state. There's often exceptions in the state laws that allow emergency medical practitioners to use electronic communication methodologies to be with a patient at the scene of an accident, but communicate with a physician back at the hospital. So those are often exempted. And there's often an exemption in a situation where a patient goes in person to his or her family practitioner, for example, and during that visit with the family practitioner, the physician pulls up on a video screen or even perhaps an audio feed, but a video screen, a specialist might be in another location. So long as the family practitioner is the principal physician for the patient and accepting principal responsibility for the patient, often then the states will say that's not a telemedicine visit that's prohibited by our state licensure laws in that way. And so in those situations, it may be possible for the physician appearing via video to be licensed in a different state and not the state in which the patient is located. Okay, next slide. Actually, we can go 2 slides ahead to the state law takeaways slide. So again, we're talking about these are the laws that govern the delivery of the health care and the limiting the way in which practitioners and facilities can make care available using telemedicine or telehealth techniques. Each state can set up their laws differently. One good example of where there is some overlap in some states, but also federal law intervention is privacy. You've got the HIPAA laws from a data security and privacy standpoint at the federal level, but then individual states have state laws governing privacy. So there's an example of where you have to be mindful of both state and federal laws. But some takeaways, I think, are what we've covered. Typically, the physician or other professional who provides the healthcare services to a patient must be licensed in the state where the patient is present at the time the patient is present. That's a general rule that most states will follow unless there is a specialist consultation like I described before. And typically the standard of care that would be required for an in-person visit must be met before the physician or other practitioner can recommend prescriptions for legend drugs or for certain therapies. And then, of course, it's important to remember that in many states, controlled substances could not be prescribed for a patient based solely on a telecommunication, telemedicine type interaction. And so that's kind of a summary of state law implications, and let me turn it back over to Brooke for a discussion of Medicare.
Thanks, Craig. So I'm going to talk about Medicare as it exists today, as well as some new developments for expansion of telemedicine under Medicare, which were included in some recent legislation. Medicare first started covering telehealth services back in 2001, and that year they paid a total of $61,000 in claims for telehealth. But in 2015, that had grown to $17.6 million in telehealth payments. So as you can see, it certainly has grown, but Medicare coverage is still pretty restricted, although expanding, as we'll discuss. So the rules are spelled out in regulations. This slide gives you a citation to the main Medicare regulation regarding telehealth. And these are kind of the key components, each of which I'm going to talk a little bit about. So you can go to the next slide. As I said, we'll talk more about each of these, but the general questions sort of in a checklist form are, is the service that you want to provide on the list of approved telehealth services that CMS publishes annually? And it is updated, and you can submit comments asking that they expand their list of telehealth services. Does the technology you're using meet Medicare's criteria? As I said, it mostly has to be interactive. Is the practitioner a type that Medicare covers, and are they licensed to provide the particular service that you want them to be providing or that they are providing? And is the patient in a place that is covered for telehealth, both geographically and in terms of the type of site? And we'll talk more about those. You can go to the next slide. As I mentioned, Medicare has a specific list of services, and it lists them by CPT codes that can be covered as telehealth services. And, this list is updated annually. It has definitely expanded from the early days. This is part of the physician fee schedule, annual notice and comment process. The services range from kind of traditional office visit codes, with E&M services, to psychotherapy and other counseling services. There are various end-stage renal disease-related services that can be provided through telehealth, advanced care planning services, just to name a few. Next slide, please. The physician or other healthcare provider at the distant site, and this is the term that Medicare uses for where the sort of specialist or telehealth provider is, not where the patient is. So that practitioner has to be licensed under state law to furnish the particular service they're providing. And if the state has, for example, a special telemedicine or special purpose license that applies to these types of services, then you need to be sure that they're complying with those requirements. As Craig said, there are definitely variations in state law requirements. Next slide. Medicare only covers telehealth when it's provided by certain specified types of practitioners. This is a list of who can be covered for particular services and be reimbursed under Medicare. And the citations here are to that earlier regulation in Title 42 of the U.S. Code. You have to make sure that the person actually meets Medicare's criteria as this particular type of provider. Next slide. In general, Medicare will only cover telehealth services if the patient presents from a specific type of what they call originating site. So the originating site is where the patient is located. The distant site is where the telehealth practitioner is located. The number of approved originating sites has expanded over time, but patients still generally have to get themselves to a particular type of healthcare setting in order for the encounter to be covered. And And then in addition to the payment to the practitioner at the distant site, the originating site qualifies for a small facility fee. In 2018, that's about $25. So it's not a lot of money, but there is at least some money for the originating site. But as we'll discuss in a minute, CMS is actually beginning to kind of dip their toe into expanding the sites where telehealth can be provided. Next slide. In addition to all the restrictions that we've already discussed, the biggest one in terms of limiting where and to whom telehealth services can be provided is the limit on geographic locations. And currently it's really limited primarily to sort of more rural areas. Unless you're part of a telemedicine demonstration project, the patient has to be at one of those approved types of originating sites, and it has to be located in a health professional shortage area that's either outside of a metropolitan statistical area, or MSA, or in a rural census tract of an MSA, or in a county that's not included in an MSA. And if that all sounds complicated, there is actually a website that the Health Resources and Services Administration operates that has kind of an online calculator where you can enter an address and it will tell you whether or not that address geographically qualifies as a site where telehealth can be provided. Next slide, please. Now I'm going to move on to some recent developments. In February, Congress passed the Bipartisan Budget Act of 2018, and that incorporated something called the Chronic Care Act, which was a bill that had been floating around Congress for a while, and included some significant provisions expanding the use of telehealth services in several ways. So I'm going to talk about each of these provisions, which apply to different beneficiary populations or in different contexts. But I think collectively they're an example of the government's interest in testing new ways of using telehealth as an effort to expand access to care and improve quality, and also give beneficiaries more choices and more flexibility. So starting in 2019, Medicare beneficiaries with end-stage renal disease who use home dialysis will have the option, they can't be required to, but they'll have the option of getting their monthly clinical assessments via a telehealth service. And that they can either be at an independent dialysis facility, which is not a site that's currently identified as an originating site, or they can even be at home, which is a big development. And the rural area restrictions that we talked about earlier would not apply. So there will be some limitations. They, during their first 3 months of getting home dialysis and at least once every 3 months afterwards, they do have to have an in-person face-to-face visit. But the other monthly assessments can be done by telehealth. And the law also specified that providing technologies to these patients would not be a fraud and abuse violation as long as certain requirements are met, and CMS is probably going to issue rules on that. Next slide, please. The Act also includes a provision that will facilitate Medicare Advantage plans to incorporate telehealth technologies. Beginning in the 2020 Medicare Advantage plan year, plans can include the use of certain telehealth services in their bid proposals. The specifics of which services they're going to be able to provide this way is going to be determined through a solicitation of comments that CMS is expected to issue by this fall regarding the types of services that would be quote unquote clinically appropriate. That's the term used in the statute. And whether any other restrictions should apply, such as training requirements or care coordination requirements. But again, this has to be an option. Beneficiaries can't be forced into using telehealth, but it will give them more flexibility to offer it. And given the growing number of beneficiaries enrolled in MA plans, this, I think, really has the potential to give a boost to the telehealth industry as a signal that Medicare is going to be more flexible in allowing use of these technologies going forward. Next slide. Another provision of the Act that provides more flexibility applies to accountable care organizations, or ACOs, which are testing ways of improving the quality of care and decreasing costs through better coordination of care. So for ACOs that have agreed to assume some financial risk as well as the benefit from any savings they realize, these are referred to as two-sided risk models. Beneficiaries assigned to these ACOs will be able to get telehealth services without being limited to a rural area or to the limited category of sites that are currently recognized as originating sites. And the law even specifies that the beneficiary's home can be an originating site, although in that case, there would be no facility fee payment. And the law also does specify that telehealth services provided at home have to be a type that's appropriate for that setting. For example, they wouldn't cover services that typically would need to be furnished in an inpatient setting. Next slide. And finally, the Act also expanded the ability to use telehealth in assessing patients with stroke symptoms. This is actually a model that's already been used very successfully in certain states and in other demonstration settings. And I think it reflects the importance of diagnosing and starting appropriate treatment for strokes quickly, and recognizing that many patients don't have immediate access to the right kinds of specialists who can do this. And so their treatment is delayed and their outcomes are not as good. So beginning in January of 2019, Medicare will cover telehealth services to diagnose, evaluate, or treat symptoms of acute stroke when the patient presents at any hospital, critical access hospital, or a mobile stroke unit. And then the law also leaves open the possibility that the Secretary of Health and Human Services may determine there are other sites that should be eligible. Again, in this case, the facility fee payment would only be made to the types of sites that are already approved as originating sites. Next slide. One other thing that I wanted to mention, which is a very new development, on May 8th, CMS announced a new rural health strategy, which is a multi-pronged effort to improve healthcare for the 60 million people who live in rural areas and have challenges often with health professional shortages, lack of specialists, and then the high cost and inconvenience of having to travel to access these services. But I wanted to point it out because one component of this rural health strategy is to advance telehealth and telemedicine. CMS has said that they believe this could not only improve access, but also reduce costs by reducing hospital readmissions, emergency transports, and unnecessary ER visits, among other things. Next slide, please. So this is a new initiative, so we don't yet know the specifics of exactly what CMS will do, but they've said that they will seek to reduce barriers to the use of telehealth. And this may include demonstrations through the Centers for Medicare and Medicaid Innovation. Next slide. I also did just want to flag that with expanded use of a service comes additional scrutiny. And in April of this year, the Department of Health and Human Services Office of the Inspector General issued an audit report on Medicare claims for telehealth services. And in that review, they examined 100 claims for telehealth services and found that 31 of that 100 had errors, ranging from either providers or sites that were ineligible for telehealth reimbursement, services that weren't approved for telehealth coverage, or the use of technology that didn't meet Medicare's criteria. So bear in mind that even if CMS doesn't always have the mechanisms up front to stop payments for claims that don't meet all of their requirements, it's still important to make sure that you're complying with all of the rules because they can come back after the fact to bite you. Next slide, please. And similarly, I just wanted to briefly flag that the False Claims Act applies to federally funded telehealth services just as it does to traditional Medicare claims. And there are some aspects of telehealth that may actually heighten the risk because there are multiple levels of providers involved, as we've discussed, possibly different state regulations, and a number of restrictions on where and to whom and by whom the services can be provided and billed. So again, it's just important to be mindful that the usual Medicare and Medicaid compliance requirements apply, and sometimes can be particularly challenging in the telehealth context. Next slide, please. And then finally, before I turn this back over to Craig, who's going to talk a bit about the Medicaid side of things, I wanted to note that although we're focusing more on initiatives by government payers, there are a lot of private sector telehealth initiatives going on, and completely outside of government-funded programs, some of which already have pretty lengthy and significant track records in terms of the quality and access to care provided and the savings realized. And one recent one that I just highlight here was an announcement from Intermountain Healthcare, which is a large health system in Utah that includes hospitals throughout the state and includes coverage of a lot of rural areas. Intermountain was already engaged in a number of telehealth efforts, but they've kind of coordinated them under a system they're calling Connect Care Pro. And it involves a pretty vast array of types of healthcare professionals and services, as you can see just from the limited list here. But in their announcement, they noted that just through the use of telehealth to provide specialty consults for newborns, they've saved over $2 million over the last few years just by reducing transports that would otherwise have been required. So I think there are really some great examples out there of both cost savings and also improved access to care on the private sector. And I sort of think, Medicare is slowly catching up to that. And I'm now going to turn things back over to Craig to talk a bit about the Medicaid side.
Thank you, Brooke. So shifting from Medicare to Medicaid, as you probably are well aware, Medicaid is a jointly funded program. Part of the money comes from the federal government in the form of matching dollars to the states, and the other portion is funded by the states. As of today, all 50 states and all of the U.S. territories offer a Medicaid program, although it's optional to do so. From the federal government's perspective, they don't dictate whether a state can have telemedicine or not. Basically, the way the federal government is involved is they provide matching funds available for the coverage of telemedicine services if a state chooses to do so. If the state wants to cover telemedicine services in the same way that it covers a traditional office visit, for example, then the state is simply allowed to make that offering, and they don't have to file special Medicaid state plan amendments or other special Medicaid applications to the federal government seeking approval. Rather, they can simply implement that program and reimburse providers for those services. However, if the state wishes to cover the services offered through telemedicine in a different way than it covers face-to-face visits, then the state needs to submit a Medicaid state plan amendment or other waiver application to the federal government seeking approval for the federal government to co-fund that service. Next slide, please. And the American Telemedicine Association has done some research and found that over 40 states currently cover, to some extent, the use of telehealth services for Medicaid beneficiaries. However, it's a real patchwork. It's very similar to state licensure laws in the sense that each state gets to decide whether it wants to cover telemedicine, how broad its coverage for telemedicine services would be, and what types of providers would be eligible to cover or provide telemedicine services and seek reimbursement. So it's critically important that providers know exactly the rules of their state and know what specific billing requirements apply when providing telemedicine services. Next slide, please. For example, some states cover the Medicaid services provided through telemedicine in a similar way that a regular visit would be covered, but for billing purposes, they require special modifiers. So there's the state of Florida, for example, requires physicians to include a GT modifier to the claim so that the Medicaid program knows this was, for example, an office visit furnished through a telemedicine communication. Some of the Medicaid programs limit the reimbursable telemedicine services to occurring in a specific location, so there are site limitations in some states. And in other states, they limit the coverage only to those physicians who are licensed in that state and enrolled with that state's Medicaid program. They may not allow nurse practitioners, physician assistants, or other physician extenders to bill for services provided through telemedicine. So again, it's very important to know what state you're looking at and what you're operating in. If a physician's in a state where there are special requirements for the billing of a telemedicine service and the physician is unaware of that and simply bills a patient consultation as if it were furnished face-to-face and didn't include the proper modifiers, there's a risk that that could be seen as a false claim, or if not a false claim, at a minimum, a Medicaid overpayment because the technical requirements were not complied with for billing purposes. So very important to know the state-by-state requirements under each Medicaid program. Next slide, please. Some state Medicaid programs, even if they do cover telemedicine services, declare that certain interactions do not qualify as telemedicine. So having a video-to-video cell phone conversation might not qualify as telemedicine in some states. Typically, emails and facsimiles wouldn't qualify for reimbursement purposes, even if in a state licensure context they might be viewed as a telemedicine activity. They might not qualify for Medicaid reimbursement. And lastly, I would note that in most states in the Medicaid programs, they're not going to provide a separate reimbursement allotment, no type of cost reimbursement for any equipment used in connection with a telemedicine visit. Next slide, please. So we've talked about state licensure laws, Medicare laws, some of the new private industry initiatives that have been developed recently, and we've also covered Medicaid. But that's not the full landscape of laws that could apply to the telemedicine industry or to telehealth interactions. Providers, health plans, technology companies, and investment companies all need to be mindful of other laws that overlay in this area. There's federal and state False Claims Act prohibitions, as Brooke mentioned, that can be implicated if items are not billed properly. There's also commercial insurance fraud prohibitions and limitations that may be implicated when someone is billing a commercial insurer. So even if it's not a government payer, there are private commercial false claims laws that could be implicated. There's also FDA medical device laws that are implicated or could be implicated by certain technologies, whether it's a glucose monitor, for example, or an app on a phone. The more the device starts to be involved in the delivery of healthcare or delivery or treatment of healthcare, the more likely it is that the FDA will have some regulation of it. And that's talking about the equipment itself, not necessarily the professionals who are involved in the delivery of care. And of course, we mentioned a little earlier the possibility and application of federal HIPAA privacy and security laws for healthcare data, as well as state medical privacy laws. All of these need to be adhered to, and folks need to be observant of when operating in the telemedicine and telehealth, digital health sector. And so with that, that's our presentation. We're happy to leave a little bit of time for questions if anybody has any.
If you have any questions, please feel free to type them, and we'll have Craig and Brooke respond to them.
Do you know if a local public health unit can be considered an originating site?
It is limited to those sites that are, I can't remember which slide it is. So if that site is enrolled in Medicare and meets the criteria for one of those originating sites, then it would, but otherwise it would not.
I've heard that a sole community hospital outside of an MSA is not an acceptable originating site. Is this true? Any pending legislation to change this?
Trying to get back to my list of originating sites. There is always legislation kind of floating around. There are certainly champions in Congress who really would like to expand telehealth services, and so there often are things out there. Whether or not they are viable and have a likelihood of passing, varies from Congress to Congress. But I certainly, would encourage people who want to, expand the opportunities for providing it to work with their member of Congress or their trade association or advocacy groups to do it. So in terms of originating sites, a critical access hospital qualifies as an originating site. So I don't know whether or not the sole community hospital being referenced also qualifies as a critical access hospital, but it has to meet the Medicare criteria for one of the originating sites listed on the earlier slides.
What about telehealth services being used in a skilled nursing facility for a patient covered under Medicare A?
So Brooke, if you, I was just going to mention that slide 24 lists some of the acceptable originating sites under Medicare, and skilled nursing facilities have the potential for being an acceptable originating site, although there are Medicare conditions around that. So it would be possible, if all other conditions are met, for it to be an appropriate originating site.
Right. I think with skilled nursing facilities, you sort of have to be careful about what is separately billable versus what's already covered under the skilled nursing facility prospective payment system. But it is, as Craig said, an originating site that could qualify.
It looks like this is the last question. If on the HRSA website it shows that my county has a designation type of HPSA geographic high needs area for mental health, does this mean that the skilled nursing facility I work in may be eligible to have mental health telehealth provided, and we would be considered the originating site?
The geographic restrictions are not varied depending on the type of approved telehealth. So I would certainly encourage them to plug the specific address into that Health Resources and Services Administration website to see whether or not it says that it does qualify as an acceptable telehealth site. And then if it does, then they would need to see whether or not the particular service they want to provide also appears on the list of Medicare covered telehealth services.
Okay, and it looks like that is the last question, unless anybody has anything last minute they want to send through.
Well, thank you, Craig and Brooke, for presenting on today's very timely topic. We also appreciate the last-minute updates given some changes which occurred in May and making us aware of the information and insights. Before we conclude, I will share a brief overview of Cinzy. Cinzy is a technology company dedicated to providing better ways for you to manage and engage colleagues, patients, and members simply and efficiently. We go beyond traditional telehealth by providing an award-winning virtual care communication platform for providers to use to engage their patients and members with video, secure messaging, text, and/or email. We enable better performance for healthcare organizations, better access for patients and members, and better outcomes for all. Please visit our website at cinzy.com or respond to your webinar invite to reach us. Stay tuned for the date, time, and topic for our next webinar. Thank you, everyone, for your time and interest. This concludes our presentation today. We will notify you when the recorded webinar is available for future reference.